So back in the day, many, many moons ago, when Internet 1.0 was a thing, HIPAA security was not a thing, HIPAA privacy was the thing. The trick question that was most popular, but most people would get wrong, is who has access? You have a patient, all right? We're talking about who has access. Your patient is 16 years old, 15 years old. Hell, the patient could be a 14 or 13-year-old female based on the way that biology works. Obviously, this child is on the parent's health insurance.
Yep.
The patient is pregnant. Does the parent slash grandparent have rights to the medical information of the pregnant individual?
I guess the answer there is it depends, right? Depends.
No, it
No?
is very, very clear. And this is the problem. This isn't just HIPAA. This is also going to hit with court cases. And this is going to be some of the problems that I wanted to flirt with as well and kind of work through out loud with you. This one's very, very clear, though. For the purposes, and this is the stupid thing, before impregnation, your patient is a child. They're under the age of 18.
Okay.
They have parents, and even if the parents came with them, right? The second that they are pregnant, the parent is completely cut off from information
Interesting.
until that patient has the child. Once the pregnancy has either come to term or the baby didn't make it, once it has been finalized, shall we
Hmm.
put it,
Hmm.
then the patient reverts back to being a child. That
Okay.
was HIPAA privacy. Can you imagine how complex this gets with HIPAA security involved?
Oh yeah.
How can we send this data if we're doing telehealth, if we're
Yeah.
doing this, if we're doing that? And we haven't even touched the crazy stuff.
Well, the
Like,
telehealth
hey, what
side,
if
it's
this?
like how do you manage that? Because what if you had
So
to I'm just going back to your scenario.
yeah,
You
yeah.
got
So if we have that scenario,
right?
right? The way that we handle it is this: unless the patient, our patient, gives us or gives you the right to know, we can't tell you anything.
Hmm. Okay.
Right now in abortion clinics, a partner can't go in with the patient. They won't let them back there.
That's I've heard about that. I've heard that.
So like there's a lot of different things that it's not just HIPAA that we're concerned about. We're concerned about this, we're concerned about that, we're concerned about this. And especially when it comes to reproductive care, we're asking questions about human trafficking and things of that nature. And who can we talk to? Who can we not talk to? And even in the setting, if I'm in an ER and you come in and you look like you got into a fight and your spouse's knuckles are a little bit scuffed, you're not asking if who are the other people looking like. You're calling the police. You're not letting that spouse anywhere near your patient. You know what I mean? Like
Yeah.
there's a lot of situations that get messy quickly because we're in a crisis situation rather than just, hey, let's just take a beat. No one is a life or death scenario, right? Okay, perfect. If they're not in a life or death scenario, we don't have a defense.
Yeah.
And even in the life or death scenario, like it's not a great defense, but at least it's something, right? So, I mean, let's start with something very, very simple. And this is something that I see relatively common nowadays. I am just a person,
Hmm.
and my brother is my next of kin. He's on all my paperwork, or my sister. My sister. Let's do sister. Sister changes her last name. Can I give her that information?
I would say no, right?
Absolutely not. You have no way to prove
Because
that she is who she is.
until she proves it, then There's nothing
The
that you.
patient did not give us, if the person that they gave us permission to speak to is Jane Doe, but she
Hmm,
comes in as Jane Brown. Jane Brown, we have no way to prove
we
that
don't.
Jane Brown and Jane Doe is the same person,
Right.
which makes this super complex when we're talking about and I see this a lot with Hispanic families where we'll do, especially from Puerto Rico, where we'll do the father's last name and the mother's last name hyphenated.
Hmm.
So, for example, mine is Delgado Molina if I did that, right? But if on some of my paperwork it says Jose Delgado, and then on some of my paperwork it says Jose Delgado Molina, all of a sudden we will have databases that clash.
Yeah.
This is a pain in the butt when we're having to deal with licensing. This is a pain in the butt when we're having to prove identities. I can have the same social security, but if my license and my social security don't match, I don't know what to do here. If I have a spouse and they hyphenated the last name, but on the paperwork they put the maiden name, can't do anything.
Can't do anything. Yeah.
I can't talk to them. The patient has to update that information. That's why it's so important. And it's annoying if you are the patient, but it's so, so, so important that patients understand that when we as healthcare offices ask, hey, has anything been updated? Has your address been updated? Has your next of kin, has anything been updated that we need to be aware of? We're asking this every bloody time we see you. And in some specialties, we're seeing you every 90 days.
Yeah.
And something changes, and you're just saying, no, nothing's changed. No, nothing's changed. No, nothing's changed. And all of a sudden, something's changed. And then now we're in trouble. Bloody hell.
Yeah.
Like if you're dealing in a certain
It,
population that gets divorced very frequently, one minute you got a patient that's married, the spouse is on the paperwork, and then all of a sudden they got divorced. Do I talk to the spouse? Do I not talk to the spouse?
yeah.
Well, according to the paperwork says I can talk to the spouse.
But you didn't.
What
They
do you
didn't.
want me to do?
Right. Right. So as a patient, you just. I mean, it's tough,
Well,
right?
so this is
You got to be
where
more.
this
You
is
got
where the patients need to.
be more akin
You know what
to.
kind of sucks about this, and I feel bad for the patients, and this is the only thing I feel bad about the patients for. They have to answer this question every time they go to a provider's office.
Well, that's. I think that's the.
And it doesn't matter the provider,
Right.
right? Like it could be the primary care, and then my kid's pediatrician, and then I've got a specialist, and then I've got a dentist, and then I've got an optometrist, and then
Yeah.
no, 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 leave me the hell alone. Nothing has changed. Don't bother me.
Well,
Let's just get the
that's
job.
just the I feel like that's just it's been ingrained at that point that that's like the answer. Like, hey, nothing's changed. Like, it's just the
And
formality.
therein
It's just
lies
the
the problem.
yeah.
Because how often do employees change their product, their insurance product,
Hmm.
when they have an employer-based insurance? That
Yeah.
happens so freaking often.
Yeah, I didn't even think of it that way, but yeah, absolutely.
And then who do I talk to? Oh, hey, let's do this one. So you get hurt at work. Can I talk to workers' comp?
And what the scenario that things have changed
If
and or
and
the
just who do I give access to information to? Like if I'm
true.
taking workers' comp, do I give access to workers' comp?
I don't think it's that easy.
Well, if it's for treatment, payment, or operations, they're covered, right? But if
Right.
it's outside of that, so if they're asking for, random things to go along with it, now we have to, all right, pause, what's going on? Now, if it's then they have to give us a subpoena. If it's like,
Hmm.
hey, we think it's workers' comp fraud or something like that, then we need more data. If it's HR, what information can we give them?
Fine
I'm
lines
in
there.
mental health. I'm
Yeah.
in mental health. I deal with mental health every day. So I deal with super confidential information. I have to sit here and even go over, okay, hold on. I have a subpoena for information. Now I have to ask the question, what are you looking for? Because I can't just give you everything
Right.
because you may be able to pierce the veil of confidentiality, but super confidentiality is a completely different matter.
No, absolutely.
You know what I mean? So it's when we're dealing with this, it's always nice to be able to simplify, right? And the way you simplify it is you have a piece of paper that you tell every patient, fill this out. These are the people I'm going to talk to, and that's it. Then it's okay. How do I prove that person is who they say they are? Usually,
Driver's
I
license?
recommend an easy, huh?
Driver's license?
Driver's license is the easiest one.
Yeah. So I
I've
guess
almost been joking with some offices because of this stuff that you almost need like two-factor authentication, right? Like I need your date of birth and
some
a
collateral
picture
here.
ID. You know
Yeah.
what I mean? Like I need to know something, right?
Yeah.
And then when it comes to other things, it's like, okay, once I've proved who you are, I need to know that, certain things about the patient too, so that way I can make sure that we're talking about the same patient. So it's almost like a triple verification process that sadly you don't want to deal with, but you have to because that lawsuit sucks. The
Yeah, you
threat of
don't
that
want.
lawsuit is awful.
Oh yeah. Yeah. And we've covered some of those lawsuits here in previous webinars. It's not fun. You don't want to be in that situation.
I mean, I have seen, and this has been a client of ours with the consulting firm, the office sent out a bill because insurance didn't pay the full amount 6 months after the data service, right? Completely common and stupid. And, Transparency Act, whoop-de friggin' do. Congress doesn't hold anybody accountable for this stuff. Anyways, so we're moving right along. So, patient calls up furious at the office. Hey, how could you send a bill to this address? I got divorced. My wife got the house. She does not need to know anything about this. Bloody, 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 so on, so on, so on, so on. And we're like, whoa, 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 time out, time out, time out, time out. And he's raven mad. And this was a long-term client of ours. So,
Hmm.
we were on retainer with them. And I went and I was like, all right, let's set up a call with the patient. Let's head this off at the pass before he goes and get a lawyer. And then we're just spending money on lawyers, and the only person that wins is the lawyer.
Yeah.
And we're like, all right, patient, Bob, just to put a name out there. All right, Bob. So what happened? Well, you guys sent the bill. Cool. That's normal. All right. He's like, yeah, but you sent it to the wrong address. And then so I was like, hey, can you confirm the address that we have on file or that we should have on file? Obviously, it's a different address. And we're like,
Right,
okay,
right.
Bob, good job. It's a different address. Hey, Bob, when did you change addresses? Oh, like a year and a half ago when I got divorced. And I'm like, well, time out. How often have you been in here? Every
Last
90
month.
days, every 4 months, more or
Yeah.
less, because it's
Yeah.
specialist. And I was like, did any staff member ever ask you if anything has changed with your address, your insurance, your
And
medications?
then Bob's like, oh shit.
Yeah, Bob's like, yeah. Well, Bob, did your address change? Yes. Okay. Hey, by the way, Bob, while I'm reviewing your chart, it's also saying on here that your ex-wife is still the person that can ask about information for you. Do you want to change that too while we're here? You know what I mean? Like, but again, so do I blame the patient for not paying attention? Yes and no.
True.
Yes, because they should be paying attention. No, because to cover our asses, we are always asking for so much information. You go to an or you hurt yourself playing pickleball, right? Like let's play the fad sport,
Okay.
right? Okay. You go to the urgent care. Urgent care sends you to the ER. ER then sends you to ortho. Ortho sends you to imaging if they don't have the imaging on site. Then you have to go back to ortho, and then you go to PT, right? Like you've got 5 different sets of providers here. You got to fill out all
All
that
that.
paperwork, the
This
same bloody paperwork, and all that's different is that the lines may move
and
around.
by that point, as a patient, you're frustrated going
I'm
through all that.
pissed off.
Yeah.
Like, couldn't I just take a picture of the paperwork the one time and just give it to you and be done with it? And
Yeah.
the answer is, I wish that you could, but you can't.
It's not that
Because to
simple.
cover our asses with all of these different alphabet agencies and all the regulations,
You need it in
now
the
we got to
fine print.
go. Yeah, we got to go and have specific fine print for every single office. Now, if the insurance is actually paid their frigging rates that they're supposed to contract with us properly, then you wouldn't have half of this problem because half the paperwork is saying, hey, you got to pay your copay and your deductible at the time of the visit. And by the way, if your insurance doesn't cover our entire fee, we get to come after you. That's always a piece of paper that's signed, and everybody
Mm,
just signs it, and then they're shocked when they get a bill because they have insurance. But anyways, so
craziness.
let's go back.
I
Let's
was
talk about more examples here.
I was gonna give you one I
Hit
actually
me.
recall for working from the weight loss clinic. Kind of interesting.
Yep.
We had a patient that we were seeing. She was on a program, and I mentioned this to you in the past, but we prescribed Adipex and topiramate as
Yep.
an in-house, and we had the spouse's husband show up to try to pick up a refill. He wasn't on he wasn't on anything. Now, obviously they had the same last name, all that stuff, but it was like, hey
Yep.
man, can't do it. And he was so distraught about it. It's like, listen, this is
Distraught or angry? Let's be honest.
he was angry.
Probably angry.
He was angry. And I I just remember telling him, I'm like, listen, I cannot prescribe this as Adipex. This is what is it, class
It's
two?
a class two.
Yeah, class two. I can't do it, you know? And
And that's the problem too, right? Like you've got to be careful with all this stuff. Because you don't want to get in trouble. And the problem is the fines are so great for you doing something on accident to help out a
mhm,
patient that that one time that you're nice, they're going to skewer you like a shish kebab, like a human
yeah,
shish kebab, man. Like it's awful.
uh,
So you can't help anybody out because then you get hosed.
yeah.
Um, we have an example. I'll use I've got two with the mental health that happened the last year and a half. And maybe I mentioned one of them before, but one of them was patient of parent of a patient. Patient is 18. Parent of a patient calls up, hey, I'm calling because um I need to get my kids eval and med list over
Mhm,
to the recruiter so he can join the military. And we're like, ma'am, he's 18. Some of this information, like, we can't give it to you.
yeah.
Can't give it to you. I can talk to you about stuff, but I can't give it to you. And they're like, but, and I'm like, the patient is an adult now. Anything that they say to us during those appointments is super confidential. I can't give it to you. I can talk to you about certain things, but I can't give you the notes and then whatever documentation that the provider does outside of that, to the side of that. That's not going to happen. Get your recruiter to send me something
Mhm,
with the patient's signature on it, and we'll send it directly to the recruiter. But it's a chain of custody thing,
yeah. Yeah.
you know. Then we had another one where,
Does that work the same for think of an example, a military family, right?
yeah,
Kids on the TRICARE. I don't know if it's any different these days, but I think it used to be 26 was the cutoff.
it's 25 because of Obamacare, not because of
Okay,
TRICARE.
25.
Yeah, at the
Um,
end of 25, right before you turn 26, they boot you off. But usually the health insurances are trying to boot the kid off from 22 on. Like they start putting pressure, like, hey, this kid needs to figure
right,
ish out because they
right.
want to get them. Remember, it's an insurance company,
Yeah.
even if it is TRICARE. So,
But in those situations where, uh, I guess adult at this point is still on the plan.
so you can be on the plan, but that doesn't automatically mean that your parents have access to your information.
Right. I feel like that
You
might be
still have
something that
autonomy as a patient.
I feel like that might be something that maybe parents aren't aware of.
It
You
absolutely
might see some
is an
scenarios like that.
issue. Yeah, it absolutely is an issue. We see this. I have seen that issue pop up more in three specialties, more than just like general practice,
Hmm.
primary care settings.
Hmm.
Usually, I see this problem in OB offices, in epidemiologist offices, not in epidemiologist, sorry, infectious disease offices, and with mental health. Because hey, I'm paying for the kids' insurance. Give me the information I need so I can do what I need to do. Sorry, I can't do that. If the patient doesn't have you on this paperwork, I can't talk to you.
Yeah.
I can't talk to you about it
Yeah.
because the infectious disease one, which is in college age people, usually has to do with an STI or an STD, even if it is
I
completely
knew where you're
treatable
going
with
with this.
penicillin or something of that nature, it is still an embarrassing situation. And it because of the fact that it is stigmatized, the diagnoses are stigmatized publicly, that's why it's considered super confidential, along with
Yeah.
mental health,
Yeah.
right? So when we're dealing with those kinds of things with OB, it usually has to deal with the reproductive conversations. Hey, why did you prescribe my kid birth control? Well, I can't talk to you about that.
Yeah. Yeah.
You know what I mean? Like, so there are certain things that you want to make sure that the patient does have rights, right? Even if they are under 18. So we had a 15-year-old, 15-year-old, come into the office for oppositional defiance disorder, ADHD, and some other crap, whatever. Parents are divorced. Patient prefers to live with the father rather than the mother. Perfect. Cool, whatever. Just mother and him lock horns. Cool.
Hmm.
Mother's demanding information on the eval. She wants the notes. She wants this because she wants to use it as leverage in the divorce and custody and child support, all that crap. Well, can I give it to her?
Uh, so the child is living with the father, right?
Child wants to live with the
Wants to
father,
live with the
wants
father.
to live with the father. Both parents brought the child in.
I would say that, well, if they're both on the same, I would say yes in this scenario. But then again, I don't know if I'm missing something, but I feel like the parent is obligated.
So here's the problem with things like this. It can't just be a yes or no. So
Who
Tracy,
has
you're
guardianship?
you're super close to what we ended up coming to terms with the lawyer. But the trick is not necessarily who has guardianship, right? Because he lives with the mom. They have split custody. The
So
trick
it's
is coming to terms with a decision and then having a defensible position as to why you made that decision.
hmm,
So if the answer is yes, you can't just tell me, yes, I can talk to mom. You got to tell me, yes, why? Right? Like this is the problem with consent. This is the problem with giving information out. If I'm going to go and do something, I need to have a yes, why? Because if things go south, I need to be able to defend what we did.
hmm.
Now, we came to the terms with based on reviewing the notes of the patient and the fact that the patient was having more issues living with the mother than the father, and mother had primary custody. We came to the conclusion that giving the mother the health information, even though he's a minor and even though he currently lives with mom, is not in the best interest of the patient. The patient is the one that actually filled out the paperwork,
Sure,
not one of the parents.
sure.
And the patient also did not put mom on the consent to give information.
There you go.
Now, if I'm a half decent lawyer, I say, I don't care. That's a minor. Going for mental health, meaning everyone is aware the patient has mental health issues. Now we have a situation. At what age can they fill out paperwork? At what age can they write, Tracy? If they can write, why can't they fill out the paperwork if they understand it? You know what I mean? Like, I would argue that preteen and above, for most things, they can fill out their own paperwork.
Hmm.
I mean, at least let them start trying to understand how the healthcare system in the US works. Like it's not in most, and a lot of places now are moving to online paperwork. So it's just click, 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 click. Yeah, you usually have the parents. That's fine too. I'm just saying, like, it comes to, and here's Tracy, where you're going to have an interesting time with this one. What happens when we're closer to the end of life cycle? We're at Medicare age. It's not about the age of the patient, it's about the patient's ability to understand what they're saying and what they're doing and what they're consenting to. Right? So we have to go and figure out, is this patient of sound mind enough to be able to fill out that paperwork? Because if we found that that patient had, for example, just using the same example, let's say he had some suicidal ideations. Do I speak to the mom then, even though she's not on the paperwork?
I would say no because HIPAA doesn't
Why?
care.
Agreed. But remember, now we're talking about something else, right? Because now
Sure.
we're talking about malpractice, now we're talking about patient care. Now we're talking about, if the patient, remember that there's clauses for HIPAA. I can disclose if there is a chance that the patient may self-harm or harm others.
Okay.
I have a duty to report.
Hmm.
Right? Like in this case, if he's just saying suicidal ideations, then I can just report it to his parents and say, hey, we need to keep an eye on him. Maybe we need to Baker Act him. Maybe there's a facility, maybe we need to treat this more aggressively and more cohesively. Maybe it's really not an issue with environment. It's not an external issue, it's an internal issue. But if the patient, especially in a primary care office, because this is where they normally see it first, is, hey, we have an issue now.
Sure.
This patient's coming in. I thought he was coming in for just a checkup, but I'm finding, let's just keep the teenager thing going, right? They're cutting themselves. Okay, well, crap. Who do I talk to? Can I talk to both parents, even though neither one of the parents are in there, but the patient is old enough to understand and consent? Well, we're talking about self-harm. Absolutely.
Yeah, I would say that
Now let's
applies.
flip it to someone who's above the age of 65 or has early onset dementia. At what point do I disregard their ability to reason and say, hey, no, I don't want you talking to my spouse about this. I'll handle it. Or I don't want you talking to my kids about this. I'll take care of it. You see that one a lot in oncology. Hey, I'm going in. I know something's wrong. Look, just don't give them the cancer results. I'll handle it on my own. And, I'll figure out a way to talk to them. What? That's nice, but who's taking care of you? That's why we have the people. That's why we have the names on that paperwork,
Yeah.
right? But sometimes that next of kin is not around, or it's not updated in the case of Medicare patients. So the spouse is dead, but they're the only person on that paperwork. So now, do I talk to the kid, the grandkid? Do they have in-house help,
Is there
a
clauses for that?
caretaker of
I'm just
some kind?
curious. Is there clauses for like cancer and things
So
like
for
that, or
cancer and things of that nature, it all comes back to the what is in the best interest of the patient as a clinician,
hmm.
right? Like our first job is do no harm. Whether we're a clinician or not, we're in that healthcare space, right? So when we look at it with that frame, do we say something? Well, no, we have to respect the patient's wishes until it reaches a point to where, hey, you need somebody to help you out with this. You need somebody to help you out with driving you to and from chemo. Chemo's kicking you in the can. You can't drive. Right? So like you're losing the ability to focus and be able to drive. You can't see it. you don't have the right state of mind, your reflexes are shot, like, hey, maybe you've had too many spinal fusions, you can barely sit in the car in a driver's seat. You need to be able to lay back a little bit more, or have your feet rested up more because of the diabetic neuropathy or the fibromyalgia, or, like, let's get deep into this, So, I
Yeah.
mean, now we're sitting here in a situation of what's best for the patient. Well, what's best for the patient and the community is, in almost all those cases, I got to take your license, which means I have to report you to the DMV,
Mhm.
which then triggers a whole nother level of a set of things, right? Hey, you need to have a caretaker. Hey, you need to set up how you're going to get to and from places. Hey, if you're not Medicare eligible yet, can we get you on Medicare now because of special qualifiers? So, or Medicaid, or, whatever state assistance is there. So we have all kinds of different situations where, because of the clinical decision making, it waterfalls into 15 different things. So
Sure.
when we look at we're allowed to talk to, it gets very, very murky, very, very fast, which is why you really want to have a, when do we talk to them? Now, in Tracy's case, she's in a chiropractic office. In chiropractic, in PC, and not PC, in PT, in
Mhm.
OT, you're not dealing with emergency cases. So you can always just, let me just take a beat. Let me just work through this problem real quick. Even if I got to throw it up on the board, hey, can we talk to this person? Your defaulted answer should be, if their name is not on that paperwork, the answer is no. If they don't have a piece of paper signed, giving that person access to the information. So if you're a chiropractor or PT or OT, you may have workers' comp paperwork, you may have lawyer paperwork, things of that nature on there, then all right, cool, you're fine. But if it's, hey, this lawyer isn't part of this, it better be attached to a subpoena,
Sure.
right? So this is where, if I'm a primary care office and I'm dealing with a workers' comp fraud, or I'm dealing with, we've had a couple of them where the patient's gotten arrested for something, right? And this is always funny to me. And it's funny to me because it's just like, crap, what did this patient get arrested for? And what can I give them? Like, so if the patient has drug abuse on there, and maybe they're a recovering rehab person that hasn't touched a lick of alcohol in 10 years, I'm giving you like super extreme examples because those are the hard ones. The day to day, hey, no, if they're not on the paperwork, the answer is no. Sorry, pound sand. John Doe can come in, change the paperwork whenever he wants because he's the patient, and we all move on with our lives. It's that simple. But when we've got something to where it's like, hey, this is the scenario, can I talk to a lawyer about John Doe's case because he got pulled over for DUI? Well, on the notes, I have recovering addict on here.
Hmm. Hmm.
You know what I mean? Like, well, I need a subpoena. If you're the state's attorney, I need a subpoena. Give me a subpoena. I'm not giving you ish because I doubt the patient's going to sign on the dotted line giving you ammunition.
Yeah.
Yeah, you know what I mean? Like, that's not usually how that works. And it's none of my business to help anybody skewer a patient, because there needs to be that trust between the patients and us. Because in order for us to do our jobs the best that we can, the patient needs to know that they can trust us. Right? Like, how much harder is our job going to be if we're treating a patient, but they won't tell us how they got the injuries?
That much
Or they
harder.
won't tell us why they're self-harming, or, like, hey, it could be something as stupid as the patient tried to overdose themselves, but they did it on Advil. You know what I mean? Like, why did we do it? What are we doing? What are we trying to achieve here? The patient needs to have that trust that it's the only person that's going to hear anything is literally these four walls and you and I. So if I have a six, yeah, so if you have a 16-year-old come in What is it, Tree? And she updates the paperwork. Would you still have the parents update the financials? Yeah, absolutely. Absolutely, because the patient's still living with the parents, right? So usually that's where the patient will just give the parents the paperwork. I just say at 15, 16, these patients are able to fill out their own paperwork. So they can, there's no reason why they shouldn't. It's okay for us to start cutting the umbilical cord with these people, like
Yeah.
it'll be okay. That's what the parent is there for anyways. The parent is usually there to drive them at the very least to the visit, if not even sit in on the visit. But hey, the parent can still be on the phone with work or handling something. The patient can fill out the paperwork. There's no reason to hold up the process of the situation for us to do this, right? Usually I've seen it to where when it comes to the financials, the patient's not even paying attention. They're just signing the bottom of the form. Because they're not the one paying for it anyways. They're not the one giving you the copay. They're not the one giving you the deductible. They don't give an ish. They have one duck to give on that, right? So
They're
on the
forced at that
main
point
thing that you
to
want
sign a
them to
data.
fill out is who you can talk to.
Right.
Now again, I'll yeah. So after the first visit, it's fine as long as we have on the paperwork. What are the names on there? So Tracy, I would say, hey, just when you're reviewing it, hey, is it okay for us to still, is all of this information good? Yeah, we still talk to your parents? Perfect. Oh, you got engaged because your spouse is going off to the military? Okay, do you want them on the information? Or are we still just talking to your parents? You know what I mean? Like
I'm getting
and
flashbacks
I'm sorry to
myself.
pick up one a little bit condescendingly, but I just
I,
gotta
I,
love recruiting.
I just I have a memory. I used to play high school football, and I had some rehab done on my shoulder. So I was seeing a physical therapist, and I remember in high school, I signed off all this paperwork, but I did put I remember I put my mother on there so that they could disclose, what they treated, what they're doing,
What you'll
etc.
see a lot with OB and with primary cares too is that once you reach a certain age where your body starts going through changes and things
Mm,
of that nature, this is when the provider will ask, "Hey, do you want your parent in here or do you just want to have a conversation with you and I?" That transition away from pediatrics to general practice it can be a tricky thing to navigate, right? And then again, remember, everybody always brings up the younger end of the spectrum, but we have to remember at the other side of the spectrum here, at the life cycle of the patient, we have to have the same conversation. When we
mm,
transition from GP to geriatrics, we're not going to OB anymore, we're going to GYN. Like there are conversations that we need to have with those loved ones, with those Medicare patients. Hey, who can we talk to after you have a stroke where you can't talk to us? You can't communicate.
mm.
Now, if they bring somebody in, like for example, my grandmother, her English is not very good looking. So whenever she would come up to see some of the providers that we know, if they didn't know Spanish, she would take one of us with her to help translate and feel comfortable and all that fun stuff, right? Cool. If the patient brings me along into the room, consent has been given. Now, if we're going to talk about something that we feel is super sensitive, we can bring it up and say, "Hey, do you want this person here for this or do you want them to wait outside?" But that's up to you. At that point, they've already brought you in.
Sure.
If we're using a virtual version of this for telemedicine purposes, if you want to take a phone call for your medical visit and you're in the back of a taxi, which I've actually had happen before, that's on you. I do not have any onus to change what I am doing to treat you based on who you have allowed into that conversation.
Right.
Does that make any sense?
No, absolutely.
So when it's especially and nowadays, especially with telemedicine, I always tell patients, look, you want to make sure that you're in someplace comfortable and secure. We are going to be talking about your healthcare. We're going to be having a conversation about your healthcare. That's why you called us. Anybody you don't want hearing, you shouldn't be around. Anybody you want around, bring them around. But that doesn't change how I'm going to do my job.
No, absolutely.
Does that make sense? So when we have, and we have to worry about Stark Law, but we're not going to worry about Stark Law right now. But if we have a multi-department practice, right, we're a larger practice or we're part of a system, what kind of information can I have bounce around from department to department? And again, it goes back to the same thing. We got to keep it simple. Anything for TPO. Details are unnecessary. If you're not going to see me as a patient, then there's no reason for you to have access to my record. This is how a lot of breaches occur in multi-location situations. Because you have a celebrity come to the practice. And of course, a celebrity's coming. That means like wildfire, the trenches know. So all of a sudden, you have someone from a cross-town branch that has nothing to do with the patient's care logging in and looking at the patient's record. Whether it's super confidential information or not, that has nothing to do with treatment, payment, or operations. That's a breach. There's no reason for that employee to have that information.
Right.
For the same token, let's say I'm a practice and I, as a sake of convenience for both work and my employees, my providers see my patient, and my providers see my employees. That barrier still needs to exist.
Yeah.
Everybody always mentions HIPAA when it comes to the patients, when it comes to the patients, when it comes to the patients. But the employees are also, if they're also patients, we also have a duty to protect. So how do we segregate that data? How do we limit the amount of people that have access? Because HIPAA is not about sharing information. It's about limiting access to information to the fewest possible. Let's say I've got 10 people in the practice and 5 of them are patients. Who needs access to that information? Well, the employee, because they're also the patient, needs access. The provider that's treating them needs access. Maybe billing, but usually you're not getting billed unless you're having to, you know what I mean? Like internally, it's a wink, wink, nudge, nudge. Here you go. I need to create a note on this because I need to send a script.
Yeah.
But if it wasn't for that, the note wouldn't be there, right? So this is a situation where you would go again and you say, hey, there's no reason for billing to be involved with this. Billing doesn't even need to know what happened. So there's no reason why anybody, and this is where the audit trails come into play. What has somebody accessed? Who has somebody accessed? Why did they access it? This normally comes up when you fire somebody. Realistically, you fired somebody. I always do just, hey, let me look at what they looked at the last 3-4 days before I fired them. And then if there's something wonky, then I'll go back further. But usually it's 3-4 days. Let me see what they did. Make sure that it's part of their job. Because if not, that's a breach. If not, I got to deal with this.
Yeah.
And maybe I fired them because of this. Maybe I fired them because this is part of the sanction policies. Like, hey, you looked up ish that you weren't supposed to, you got to go. In the example of that celebrity, there's no reason for you to be looking at this Tom Cruise's health information, just to put a name out there. Normally you see this a lot with college athletes. Because the college is connected to the local hospital and an injury occurs at the sporting event. And so
everybody goes
to the hospital and you have everybody being like, not our local hero. And
Let's go in
oh,
there and
let me
see what
see.
happened.
Yeah, let me see what the diagnosis is real quick. You know what I mean? Like, no, you can't do that, boo-boo. And then if there's five of you looking at this ish, guess what? The
They're
one
all,
person that's going to get fired for sure is the one person's that was logged in.
yeah, yeah.
This is also why you don't give your login to anybody. Because if they have your login, they have your career.
Great point. Access
You
controls.
trust everybody with your career. You just met this person when you're working with them. You don't even know if they're a real friend or if they're a work friend. You know what I'm saying?
Yeah, yeah.
Yeah, we cool. And then you quit the job or I leave and we never talk again.
Which in most cases, in that particular scenario, that's probably that's gonna happen.
Well, I
Crazy.
mean, in the scenario that I'm talking about specifically, this happened and this hit the news a couple years ago with UF Chance. And Chance had to do a whole investigation. Five employees ended up getting fired, but four of them ended up getting fired after the fact, after quite a bit of investigating. The one person that got fired, like literally, boom,
Was the one that logged
immediately
in.
was that person that it was audited to have checked in the record. And then I think that person just rolled over on everybody else and said, screw it. If I'm getting fired, everybody's
Whistle
coming down
blew
with me.
everybody.
No, well, it's not a whistleblower. You're just snitching and
Well, you're
hoping you don't
just
go to jail,
yeah, yep.
right? Like at that point, you're just hoping that nobody presses charges. Which, let me ask you a stupid question now. Is the hospital the one that can press charges or the patient?
I would say be patient, right?
Absolutely. And just because I fire the employee does not mean that I, as the hospital, am in the clear.
I was gonna say the patient can sue the hospital in that
And the patient can sue
scenario.
both.
Or both, yeah. Yeah. The individual and the hospital. Yeah.
And that's the liability. That's why it's so important. And the worst part is a lot of these EHRs, they're not going to tell you this, but they really can't segregate things the way that they need to be. They cannot follow the HIPAA regulations the way that they are written or the way they are intended because they don't have that capability. And most practices aren't of the size to where it warrants it anyways.
And you're talking about like
But if
in
you're
terms of access levels and logins and yeah, yeah.
access levels, location access, job specific access, all of these things are supposed to be a matrix, and most EHRs can't do it that way. Most EHRs have it set up to where you have job
Basic
specific.
access. Or
Yeah,
yeah,
you
well
have
that
jobs,
job
you have
specific.
type specific, tier specific, right?
Yeah,
They'll
yeah.
give you master access is with the providers, and then limited access with mid levels, and then like pretty much read only as entry level. But you can still view
See
everything
everything.
that's on that database.
Yeah. It's interesting. You would think they'd be able to
It's
figure something out with that, but
no, it's too complex of a problem,
yeah.
right? Because even if I solve the problem on the programming side, I set it up, hey, each separate location has its own basically EHR within the giant EHR. What data needs to move from department to department, location to location? If I'm a hospital system, the nightmare that this would be.
Mm. Oh yeah. Yeah, I can
Because
see
just
it.
because someone goes to the ER doesn't mean that they always go to ortho or they always go to general surgery or they always go to primary care. You know what I mean? But they could. How do I give that? I'd have to one by one give that person access, the department access, so
Yeah.
then the department can decide on the employee. No, 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 no. It's
It's a rabbit
this is
hole.
where this is where if I wanted to follow all of the rules and that information was going to be super safe, I put it in a box and drop it down the Mariana Trench. So nobody has access to whatever. Guaranteed no breaches. Guaranteed it's going to be super safe. But you can't get that data.
No.
You'll never be able to get that data. And then in another alphabet agency, it's telling us, no, no, but we have to store the data and have access to the data for a certain amount of years based on if they're a Medicare Advantage patient, if they're a minor, if they're this, if this is that. You know, it's annoying.
Yeah.
It's annoying, man. It's absolutely annoying. So this is where you need to just figure out what are the rules that we need to play by? What are the most important ones? And then keep in mind how we can kind of address the intent if we can't follow the letter. What the EHRs do, and I've talked to several in the last month, and by several, I mean literally at 8 or 9 in the last month. Uh, Most of them just segregate it by job class.
Hmm.
They don't segregate it by location because of the onerous issue on the programming side and then on the admin side. Even if they were able to do it on the programming side, so many admin people would Mitch about it and complain about it, but then they would end up having to not do it anyways and just approving it all and then moving on. An example of this is the most EHRs have a section where you can click all, and it usually adds a signature or it sends out super bills. And it is a giant problem because you should not be able to just click
Click.
everything that is in this and it
Yeah.
just all gets sent because it causes issues. But for the convenience of the client, they do it. And they say, risk is on you. I'm not touching it. Here you go. So you have to dot your T's and cross your T's and dot your I's. Have to,
Absolutely.
have to, have to, have to.
A lot of room for error.
There's a lot of room for error. But again, it's on the day to day, this is simple. It's when we find these interesting cases. The if then, but it broke it here and then it breaks it there. And this is why I tell you, you should have a relationship with either a consultant or a lawyer. Because then when, on those odd scenarios, it is worth paying the $300, $500 to have the conversation if they charge you to just be in the clear, and then your defense can be on advice of counsel.
Yeah. Yep.
It is, if you don't know the defense of on advice of counsel, it is massive. When you can push that liability off, push it for $300, $400, hell, even if it's $1,000. If this one case bites you in the keister, you're looking at $25,000 because it's HIPAA, it's per incident, and then and then you're going to have civil fines, and then they're going to sue you because then once you're
Put your
screwed by
pride
HIPAA,
aside.
now you have cause. If you didn't have the cause before, now you got cause.
Right.
And now it's guaranteed because you're already proven liable. You know what I mean? Like it's just wild. It's just wild, man.
That'd be something to
It's
talk,
just wild.
have Sam on for, discuss those back ends.
Yeah, yeah. Actually, you know what? I need to reach out to
I'm
her.
sure
I
she's got
talked to her a little bit last week.
some
I need to
stories
reach
of,
out to her and I'll see if she can't come up with a few interesting cases or bring up some interesting stuff that she's had recently. I hate to say it, but I'm a bit of a nerd. When these situations pop up, I actually sit back and you'd almost think I'm some kind of conspiracy theorist because I start playing with the if thens and then the string is here and it's connected to this push pin over here and then you just see it and
and then
yeah
you're like,
it's
okay, let me call Sam up. Pay
well
the
no because then it's
$300.
like okay then what I'll normally do is I'll sit there and be like all right I think I've got the answer but now I got to go and test it.
It's true.
So this is where I'll either call Dr. Delgado or I'll call Sam or I'll call one of the other attorneys that we work with and I'll work through the case and be like, okay, where am I vulnerable?
Sure.
What do I need to be what are the attack vectors if I said this is wrong?
Good way to do
right?
it,
So
man.
now we're playing chess, not
I
checkers.
was gonna say we're playing chess now.
Yeah, you got to play chess. This is all about, and remember, thanks to the PPACA, if we screw up, it is automatically assumed that we had malintent.
Yeah.
Thank you, Saint Obama. So yeah, so if anybody's got any questions, let's throw them up. I know we went a little bit long, but this stuff it gets again
No,
it
it's
gets
good
interesting fast. And
information
we
and
had a couple quick
good
well, we had a couple
scenarios.
quick bunny trails too. So I mean, if anybody
I
wants us
like
to
the
go into those
stories.
bunny trails a little bit more on their own little chats, just let us know. We'll be more than happy to.
Yeah, if anybody's got some scenarios, throw them in. We can play some chess through them.
I mean, this stuff is always fun for me. Yeah, I mean,
No, some of the scenarios that you brought up, I just never would have thought of thinking of, you know what I mean?
well, and
But
that's
then
the
again,
problem. The people that wrote
I'm
these
not on the
laws.
clinical side, but it's definitely these are scenarios that I can see happening more often than you think, you know?
Well, the problem is that these scenarios happen frequently enough
Yeah.
that the laws themselves didn't ever, because the idiots writing laws for healthcare don't know anything about healthcare.
They don't deal with
We
them day
have
to day.
we have 535 people in Congress, in federal Congress, not including state, that dictate what we do in healthcare. How many of them have any experience working in healthcare? I'll wait. I believe in this incoming Congress, there out of the 535 federally, I want to say three are actually providers.
Bad.
Everybody else has been a patient. They don't know anything about, hey, you're writing things that completely contradict this over here and that over there and this over here. So now we have to sit here and pay lawyers and wait for judges to come up with, well, I guess based on this, or this supersedes that. And it's just a mess.
That's
It's just a mess. Just look at high tech and Stark. They're a freaking mess now because the incentives that CMS has completely contradict these rules.
oh,
So, I mean, how do you collaborate if you can't talk to anybody? You can't collaborate.
yeah.
Like it's just,
It's
it's just, it's just dumb. It's just
you can't
dumb.
win.
But it's the environment that we find ourselves.
Yeah.
So cool. So
Well,
then next week, what are we working on?
so next week we're going to be talking about the article you sent over on Aetna.
Oh yeah,
That's going to be a
yeah.
good one.
Edna, you're first, but I cannot wait for something like this to be happening to all these insurances. Ooh, if you don't know, it has to do with the No Surprises Act. That the only people complaining about it are the hospitals and the insurance companies. Go figure.
I put the article in chat for anybody that's
If anybody
interested.
wants a sneak peek, anybody wants a sneak peek, here you go.
And then the week after, I spoke to your dad earlier this morning. We're going to be talking with him. He actually released an article released recently on the key trends in healthcare as we start 2025. So we're gonna dabble in that. I know he's got some private equity stuff he wanted to talk on, some growing cybersecurity concerns, and there's a couple major HIPAA settlements that he wanted to talk on. So it'll be a little bit of everything with that.
Okay.
And then I actually found, maybe you're aware of this. I just learned of it today, but apparently Apple uh, has class action lawsuit about Siri eavesdropping.
Oh yeah.
I guess
Oh man,
anybody that
I
was
heard
affected
about it.
between 20, anybody that owns an Apple product between 2014 and now, I guess is entitled to make a claim for $20. This is crazy. But it's
I
a
mean,
$95 million. It's a settlement.
It's
I mean, it's
probably
big
gonna
money.
end up being $20 a person,
And it
but the
was
problem is that that
well,
one is huge.
I think that'll be interesting to talk on in a healthcare perspective because I know we've done a webinar in the past. We talked about cell phone usage, and man, you'd be surprised how many practitioners out there are using their cell phones, and
I'm
let alone,
curious to see how that also affects AI
yeah,
because a
yeah,
lot of these AIs are basing data and compiling data based on databases that just grab information. So I wonder if any of that stuff is in there and that affects the data. So it affects the decision making.
yeah. It might be that might be an interesting one to talk about. I'll do a little more research on the healthcare side of things, but yeah, long story short, anybody that has an Apple product and uses Siri, they sold that data off to somebody. So anything that you talk to in your Siri got sold out, which is just crazy. Um,
Do you know how many providers have Apple products
I, I was gonna say,
in
I mean,
healthcare?
I would argue
Are you kidding
99%,
me?
99.9%.
The providers,
Crazy.
not even staff, but the providers, the amount of providers that have Apple products is the bane of
Yeah,
my existence when we're dealing with databases and everything else because Apple products don't play well with anything else
yeah.
other than other Apple products. So it's a giant, yeah, no, that's going to be a
It's
boondoggle.
it's a pretty big deal, but I think that'll be a good one to talk on. That would be so next week we'll talk about Aetna. The week after we'll talk with Dr. Delgado, and then this will be the 28th. We'll talk about this, and
I
then
wonder, well, I wonder if, see, now this is a situation where I'm thinking, if I have a doctor that I know has an Apple product and they've had an Apple product,
hmm,
would I, because we're in a litigious society, would I be able to sue that covered entity? And I don't think so because it would have happened without the covered entity's knowledge and they're not a business associate because good luck getting Apple to sign a business
I just
associate
look at it
agreement.
in the perspective of PHI and
No, that's what I mean though. Would this be covered under incidental disclosure for the covered entity, not for Apple?
I see,
Apple messed up.
I see. Don't know. It's a good question. Yeah,
Let me kick it around.
I'll do a little more research on the on how this has affected the healthcare industry and see if I can dig something up.
Yeah, let me kick it around though in my head. We'll talk
Yeah,
about it. We'll talk about
for
it.
sure. Well,
But all
no, I
right,
appreciate
guys.
everybody hanging with us today. I know it was a little longer than usual, but I hope you found some value out of this episode. If you haven't already, please go to our YouTube channel. You can just search EPICompliance. Please like and subscribe. We've been doing these webinars since October 2023. This will be episode number 58 now. So we have a pretty big
Yeah, I
catalog
bet you
of,
that would be covered under incidental because you
you
wouldn't
think?
have known. And if anything, the covered entities would be able to have a lawsuit with Apple for not protecting the data properly.
I mean, that makes sense. There's got to be some. There's got
Interesting.
to be something. I'll dig something up. I'm sure there's going to be
Interesting.
something.
But then again, based on the time frame, it may not be actionable anyways because it's so far out. Because we're almost 10 years out from the
Yeah,
case, from the
yeah.
affected years. So then none of this may matter because of the statute of limitation. You're seeing me do this conspiracy board
I
right
know. Look
now
at you.
live, guys.
You got 3 weeks to think this one through. So there you go. You got plenty of
All
time.
right. All right. Perfect. We'll talk then.
Sounds good. Well, all right. Thank you so much, everyone, for attending. We'll see you guys on the next episode. Just look out for an email for the registration. It should go out sometime this afternoon. So
Perfect.
thanks again, Jose, and I'll see you
Yeah, no
next week.
problem. See you soon.
Yep. Take care, everyone.
Sunshine.